This, presents us now into our open, questions, from our webinar attendees. And I want to thank everyone for your time. And I'm going to hand this over to Veeru.
Thanks, Stephen. So, guys, this is your opportunity to interact with the authors. Questions can come in now if you want, and in the meantime, we'll start asking some. So I've got a really nice controversial question from Alistair Lamb. So I'm going to actually get each of your opinions on this. So Alistair Lamb has asked, is there a general agreement now that we don't need to investigate non-visible hematuria? Does this apply to all patients or just young patients? So maybe first I'll go to Angie.
Great question. I'll just speak for my own practice. I don't think I am comfortable yet to say no patient with non-visible hematuria needs a workup. Because the Identify study, there are still some cancers, the prevalence is lower, but they still exist. And certainly we've seen in our practice, my practice is almost exclusively bladder cancer. Many are picked up with non-visible hematuria. Now, many of those have other risk factors. So I do factor that in. I would just amend that I wouldn't say all, but I do think that the low risk category, probably young patients, no smoking history, don't need a cystoscopy. And then in terms of upper tract imaging, I would take that a little bit more. So perhaps these upper tract urothelials who have very low risk factors, or even just less than 60 years old, if you want anything, maybe an ultrasound, but no, I don't generally do CT scans. So I think for cystoscopy, I can't in my practice, I don't just say all patients don't have cystoscopy. I'm not there yet. I feel like we need more evidence before I can make that next step.
Thanks, Angie. And I'm going to ask the same question to Sinan.
Yeah, I think one of the best ways potentially to think about visible and non-visible hematuria is potentially a spectrum. So rather than treating them as a binary variable, think about them as, okay, this patient has non-visible hematuria. Maybe in a few years' time, as the cancer develops, it will become visible hematuria. So you have to, very much as Dr. Smith was saying, take into account the other risk factors that will increase that patient's risk of cancer, especially bladder cancer. Using something like a risk calculator can really help with that, because you can have a patient in front of you with lots of risk markers, but non-visible hematuria, and their risk is higher than a younger patient with a UTI and a visible hematuria. So that's how I would think about it.
So I think in summary, the consensus, Alistair, was no, not everyone. Use our risk calculator, combine it with the other risk factors, and you'll get your answer.
Very well put, Veeru. So I'll take the next question. This comes straight from the top. So this is from Dr. Freddie Hamby. This is a terrific debate, but what is the next piece of research that is really needed, if any, to consolidate evidence to manage these patients and change guidelines globally? And where are we with urinary markers? So I'm going to hand this over to you, Maria. What are your thoughts?
Well, I can start by the second. Where are we in urinary markers? Yeah. Honestly, I don't know how to answer you, Fred. Thank you for the question. But the truth is that we have markers that have been studied, and where do they seem that could help us? Probably in the follow-up once we have a diagnosis of bladder cancer. So in this setting, it seems that molecular markers could be helpful, but we are not talking about this setting. We are talking about a setting that it's quite more complicated. That is the screening or the primary diagnosis So what do we need? A perfect combination of sensitivity, specificity, etc. And the prevalence of the disease should be enough to understand that we should to use these markers. It has been said, for example, why we don't use it in a very specific population, smokers over 50, etc., with all the risk factors. But the truth is that those that are really good in the follow-up because a good sensitivity and specificity that sometimes reach the level of the cytology, although not all of them, and not at the level of the cytology, because we have a very good marker that is cytology. I think that by the moment we are not prepared for using them in the routine practice, but as I have been said for 20 years, I do really hope that in the near future, we will use them.
Excellent. And I guess, Angie, do you have anything else to add to that? Particularly also too, I know we are, you and I, with health services research, taking these data and try to understand how we can apply these. We have the risk stratification, but what further research now is needed for implementation, dissemination, and particularly maybe value care and cost of care?
Well, sure. I mean, I think all of the above, right? There's cost effectiveness analyses that could be incredibly useful in this regard. I mean, this is ripe for that. I also think that with regard to dissemination and implementation, I think we're maybe a little, not necessarily early for that, but I think we have to get a sense of like the algorithm that we choose to use. Maybe it's the AUA guidelines, risk stratification, EAU is developing theirs, but having some kind of algorithm and then trying to disseminate, implement that and study how that's going to be done, because that's going to be a challenge. But I also am interested in Sinan's thought. He had his hands raised. I know that he's been thinking about this as the lead author of this study. I'm sure you put a lot of thought into your next steps.
Yeah, I think I just wanted to echo a lot of what Dr. Ribal said, in that you need these components to build your diagnostic pathway. So yes, you have the prevalence data, but then you need the risk stratification system, whatever that is, followed by the test accuracies to then assign to each level of risk. And once you have that pathway, I think realistically, you're going to probably need to do some sort of trial, a non-inferiority trial, but also build into that health economics to show that the new diagnostic pathway doesn't miss any more cancers, is a better use of resources, and saves money as well. I think that would probably be the final evidence that's needed to show everyone that's the way to go.
And I assume that this is in the works then.
So from the Identify study, there will be the risk stratification publication to come, and the diagnostic accuracies, which will hopefully build the pathway. The trial, who knows?
We believe in you.
Thanks, Sinan and Angie. So we have another question from the audience from Atif Khan. And this is going to be to Angie, because she made a comment on this earlier. So he said, we send a lot of patients for upper tract imaging to detect only 1.1% of upper tract disease. What's the pragmatic way to go ahead?
Yeah, so in my practice, anyone who has low and even intermediate risk, I either don't get any imaging at all, or I might get an ultrasound at best. I think an ultrasound has very minimal risk. It's cheap, it's easy to perform. And I think you're going to find, if you're gonna, it might not be the perfect test, but you're gonna detect something that, you're not gonna miss a big cancer, or you're not gonna, you're gonna see something, and maybe it's hydro, maybe it's just like a mass, and then maybe you get the CT scan. But in general, I don't use upper tract anymore. Now, if I have a patient with risk factors, visible hematuria, and who is older, I do, for those patients, get a CT urogram in those, only because I know their risk is higher. But it's very few and far between that I get CT urograms anymore for non-visible hematuria. And even for visible hematuria, I try to reserve that for the higher risk patients. But I always have the discussion. So I'm always talking to the patient about this. And that's what kind of goes back to what I had said before. You have to be really solid in what you believe so that you give a good pitch to the patient so that they trust what you're saying and they make a good decision based upon not your bias or your fear of missing a cancer, but rather what the data are showing you and what you think is best for them.
So I think this leads me on to two questions. One is going to be for Sinan and one is going to be for Maria. So Sinan, do you want to give a sneak peek of how ultrasound performed for the upper tract cancer diagnosis compared to CT urogram?
So off the top of my head, you put me on the spot, but ultrasound was not as sensitive as CT in detecting upper tract urothelial cancer, and I think that's known. That doesn't come as a surprise. It was, however, more sensitive at detecting bladder cancers than CT, more interestingly. And if you ask radiologists, they'll agree with that and find the logic in that. However, the most important thing I think was the specificity between ultrasound and CT was very, very similar. So it was something like 98, 99%. So, you know, patients are more interested in specificity, doctors are more interested in sensitivity. So that's what I would say. And I think ultrasound is a good tool, at least for example, an intermediate risk patient to begin an investigation.
Thanks, Sinan. So we've got a really interesting comment from Andrew Dickinson, which will lead into a question for Maria. So Andrew Dickinson was one of the authors of the original Edwards paper. So thank you for listening, Andrew. It's great to have you and your expertise here. And he's very happy with the data we've produced. And he suggested we just need to trust the data and not over-investigate. So Maria, the EAU guidelines panel are doing a lot of work on implementation of guidelines. Can I ask you what you think the main barriers are to changing practice and reducing this over-investigation we've highlighted?
Wow. Well, the truth is that this is the $1 million question. It's true that we are working so much from the EAU guidelines on to understand, because it's not only important to disseminate. For example, EAU guidelines are endorsed by 75 urological societies. So it's worldwide used, and we are happy for that. But this doesn't mean that people is using really our guidelines. For example, we have had a lot of publications saying, for example, in this country, the strong recommendation of performing an immediate instillation in bladder cancer is not followed, or the use of androgen deprivation in prostate cancer is more, prior to radical prostatectomy, is more than X% when it should be known, 0. So the truth is that the implementation of the guidelines is something that we are now working for the last 3 years. We have a project that it's called Imagine, and we are testing with national societies and working with several hospitals around the different countries in Europe and different types of hospitals. We are testing some of our recommendations, and we are recruiting data on how these recommendations are being applied in the different type of hospitals, academical, small ones, private, in different countries. So we will have this information. In fact, we already have information about the use of neoadjuvant hormone therapy prior radical prostatectomy, and we will communicate during our next EAU 22. And which is the second step? Once you know how your recommendations are being implemented, the next that you should do is a second step study, just to understand why those recommendations are not being followed or why they are really well followed. So you need to structure good surveys to understand with national societies, key opinion leaders, local representatives, which are the barriers, because the barriers are several. Sometimes it's a healthcare issue, government's issue, local disponibility of the things. We are saying that the robotic is great and robot is not everywhere. We are saying that this drug is marvelous and this drug is not available everywhere. We are saying this drug is perfect and perhaps it's not accepted in every single country. So there are a lot of barriers that should be taken into account. But the truth is that the only and the main reason for existing for the guidelines is that they are already implemented. It's the only way that we can ensure that we are practicing the best way for our patients.
That brings us to, can you believe it, already an hour almost has come up, you know, such a great discussion. You know, I personally want to thank, you know, our panel, but also to our guests that have attended, you know, such a wonderful discussion. And Veeru, do you have anything else to add? I know we have our Twitter is open, so if anyone has some questions that didn't have a chance to post them, please do so.
Thanks, Stephen. I wanted to echo your thoughts. Thank you, everyone, for attending the webinar. Thank you to our expert panelists and to the BJUI for this unique way, really, of portraying the science in an exciting and engaging way. And I hope you've enjoyed the discussion. I'd like to thank the funders of the study and also the patients who took part and all of the collaborators who contributed data to make this collaborative effort, which is a new way of doing research, work, and without whom we wouldn't have a study to talk about. So I'd like to encourage you all to go onto Twitter for 48 hours only. You can ask any questions you want, and one of the authors and some of the BJUI editorial board members will be around to address those. So let's get some active discussion going, and thank you very much for attending.